Good afternoon, everybody, and welcome to this special session, Lost in Translation, Health Systems and Innovation Transfer, as part of the last day of the EHMA conference. I'm George Valiotis. I'm the Executive Director here at the European Health Management Association, and I'll be moderating today's session. It's a 75-minute session, and don't forget to stretch your legs. You can get up and walk around while you're participating to make sure that you're feeling limber and comfortable. I'm going to spend just 2 minutes summarizing what this webinar will be about. Then I'm going to introduce you to our speakers, and you'll have about 40 minutes from the speakers. And then we've got lots of space here for questions and answers from you guys. And we really encourage your questions because this is all about collaboration, this very piece of work. So if you did want to ask a question, at the bottom of your screen, you will see a Q&A box. So you can type them in there at any point. At the end, once the speakers have shared their expertise with you, you can also put your hand up. And if you wanted to speak live, then we can activate your camera and your microphone and hear from you. So let me introduce you to the speakers. We have an incredible range of speakers. We're very fortunate with this session. So we have Dr. Nick Fahey. He's an expert advisor to the European Observatory on Health Systems and Policies, and quite a bit more. I can tell you about their biographies shortly, actually. So we'll hear from Nick for about 15 minutes, 10 to 15 minutes, and then we'll go to Dr. Johan Hansen and Professor Ellen Nolte, and together they'll speak for about 20 minutes. And then to Sabrina Montante, who will finish up giving you the overview about this project, and then we'll go to your questions. So let's start off straight away, and I'll point you to Nick. So I want to tell you just a little bit more about Nick because his profile is absolutely so impressive. So he's a research and consultant in health and policy systems, looking at how health systems work. What we can learn by comparing health systems across countries and how to bring about constructive change in health systems. His background is in international health policy, including over a decade in the European Commission. And I won't take up any more of his time because his profile is that long. So Nick, welcome. Thanks for joining us.
Thank you very much indeed for that slightly embarrassing introduction. And good morning to everybody. It's a pleasure to be back at the EHMA conference after having been here many times over the years. And I'm very grateful for the invitation to be able to contribute and to make the sort of, my presentation is the appetizer in this session. And then the two principal dishes will be from Johan and from Ellen. But let me get us started with a presentation. I'm going to talk about this learning from the context, as it were, to health systems learning from each other. And this is the background to the 2REACH project. And I'll talk a little bit about that background and about the origins of the project and the challenge that it was seeking to address. And let me begin by, let's ground this a little bit and talk about different types of innovation. And I'm going to use an example here, which is a process for ensuring transfusion safety. That is how we can give blood to patients and do so safely in a way that ensures that it matches the blood groups and profiles of those patients. And this particular case gives me an opportunity also to acknowledge funding and support from the UK's National Institute for Health Research for the Oxford Biomedical Research Centre, which is support both to me and to the colleagues through whom this particular piece of technology and study was developed. So let's talk about the nature of innovation. And here we see an innovation. We see, and what you can see there specifically, the hands wearing gloves are the hands of a nurse. And the nurse is holding in their left hand a blood transfusion bag and in their right hand a barcode reader. And you can see that at the moment they're using a barcode reader to read a wristband, which has a barcode on it, which is being worn by a patient. And there is also a barcode on the blood bag. And you can probably guess what's going on, right? We're using these barcodes to make very sure that we are correctly identifying the patient and therefore the blood type that the patient needs, and that we're also correctly identifying and tracking the blood which is actually being provided so that we can make sure that those two things match and that we can make sure that we are monitoring the process of how this blood is going through the system. So this sounds like a nice, simple, technological innovation. But in order to make that technological innovation work, we need a whole range of processes, and you can see on the screen the whole set of different processes which are involved. We have a whole process of ensuring we collect the right information from patients in the first place. There's the ordering process. There's then a whole physical process of going across the hospital, having the blood type matched in the laboratory, physically bringing it back, tracking it. So you can think here about a whole other kind of innovation and change which is taking place, which is a set of actions, a set of changes in procedures, a set of new technologies, which require the involvement and the change of a whole set of individuals and a whole set of organizations within the hospital. And that is a process of organizational innovation. And I want us to keep that distinction of a technological innovation and an organizational innovation in mind, because that's a distinction which is fundamental to the issues that the 2REACH project was addressing. And just to put this in context, in case you think that this process is simple, and I suspect that anybody who's tried to do anything like this in a hospital doesn't think that this is simple, the study that we're looking at here, it took at least 10 years to implement this process in a functional day-to-day basis throughout the hospital here in Oxford. And to be honest, the colleagues there are still working on it many years after that. So this is not an easy thing to do. So bearing that specific example in mind, let's talk about how this relates to the wider challenges that health systems face. So we know that European health systems have shared values and face shared challenges, and we'll have heard a lot about those challenges during the EHMA conference and previously. And I've drawn this distinction between the types of innovation that we face in terms of biomedical and technological innovation on the one hand, and these service and policy and organizational innovations on the other hand. And they're all taking place within the highly complex context of health systems. And I'm going to talk a little bit more about what that means in a few moments. And Europe itself creates a shared context for all of these different health systems through the support that it provides, through the regulatory and financial and policy context that it creates around European health systems. And that also gives us an opportunity. It means that we have the potential, more than for any other group of health systems anywhere in the world, to be learning from each other and to be benefiting from each other's experience. But we still face real challenges in trying to understand how that process can work. And this is not a trivial challenge. So implementation, putting things into practice, always sounds like the easy bit. And so we think that the hard bit is coming up with the technology in the first place. And I'm not saying that it isn't hard, of course it is. But this whole process of bringing about the organizational and the systems change to bring those innovations into practice, that's also really hard. And we can see how hard it is because very often it doesn't work. So you can see here some illustrative examples of a very established phenomenon, which is that we see very wide gaps between what we think should be happening based on our evidence about beneficial innovations and what is actually happening within health systems. And some of that is obviously down to adapting care to the individual needs of patients. But the levels of variation clearly go much beyond that. And they also reflect this challenge of the different unique contexts of different health systems and different organizations within health systems. And so this challenge has been there for decades, and it's a crucial challenge for us to try and address. So how might we do that? Well, this, colleagues, is what we call shameless self-publicity, because I'm picking out one particular framework from the literature for implementation because I happen to be involved in preparing it. But I'm using it as an illustration to look at some of the factors, some of the ways in which we can take those complexities which I talked about in that first slide about the safe transfusion technology and try and put a theoretical framework around them. And if you think about what this slide is telling us in relation to that, so we might think about blood transfusion is different for different conditions. So for example, in surgery, the needs for speed and quantity of blood transfusion can be very different to in other instances. There are many different technologies for how that can be done, different actors who need to be involved. We saw the wide range of staff and different other actors like administrators, porters, laboratory technicians, blood donors. So there's a big system which is related to that, all of which has to come together into something that adds value. There's the wider organization and the wider system. So you can see there's ways of thinking about this. I don't make any claims that this is the only way of thinking about it. I'm just saying we can use models from the literature to try and understand how this process of implementation and scale up, spread and sustainability works in practice. But it's taking place within this complex context of health systems. And you'll see here, we just have the wider system as a general box. And let me now talk about what I mean about this complex context. And I want to distinguish between three types of system and three ways of thinking about processes. And let's start with a simple one. And I hope you had a good breakfast, because this slide is normally guaranteed to make people feel a little bit hungrier than they were a few seconds ago. Let's make a sandwich. Recipe for making a sandwich. It's simple, it's straightforward, it's predictable. There aren't many different elements to it. You might mess around with your types of cheese or your other ingredients, but basically you can make exactly the same thing every time, and it doesn't require any particular skills to do that. Now, the classic example that we use as something that's really difficult is we say, well, it's not rocket science. And so let's think about rocket science. Rocket science is definitely complicated. It has multiple interacting components. It does require particular skills. It does require lots of different elements to fit together. But in principle, if you can fit those processes together, if you can do the same things in the same way every time, you will get to the same result. And that's the process that allows rockets to fly on a repeated basis. It's how we run potentially high-risk industries like aviation. Airplanes take off and land safely time after time, because you can predict and control and carry out that same system each time. So that's simple and complicated. Complex, well, a complex system is one that, as any parent will tell you, is one where if you can do exactly the same things with two children, and you can do them at the same time in the same order, will you get the same children? No, you will not. Will you get the same reaction? No, you will not. And that's a complex system, because there are actors in it who are acting in their own way for their own purposes. And in principle, any large system with lots of people in it, or where the outcomes depend on the actions of those people, you will quite often find as a complex system. And they require different techniques, because you simply can't get to the same results every time by trying to do the same things every time. That's a complex system, and that's the most helpful way of thinking about health systems. But I said earlier on that we were talking about how we would learn between systems. So if each individual system is a complex context, how do we learn between them? Because these implementation models, like the one I showed you a few moments ago, are focused historically on learning within systems, which is already hard. So how can we realize this European potential of learning between systems when we know the context is vital? We know that each health system, even if they have the same values, is itself a unique context. And so we need to have ways of understanding these different contexts and how to move between them. And if they are both complex, this is really hard. But it's worth trying. It's worth doing, because there is such enormous potential. We talk a lot, for example, about demographic aging, the aging of the population as the key challenge facing European health systems. It's actually not. When we look at the overall magnitude of the impact of increased costs from demographic aging, and then we look at the scale of the challenge from innovation and its implementation, the scale of variation in implementation alone is orders of magnitude larger than the change in demographic aging costs. Put another way, if we could realize the potential of better innovation and better implementation, we can pay for the costs of demographic aging and more. So although this learning between health system challenge is a hard one, it's one absolutely worth trying to rise to. And that was the aim of the 2REACH project, the transfer of organizational innovations for resilient, effective, equitable, accessible, sustainable, and comprehensive health services and systems. So, in conclusion, I want to emphasize that innovation is central to health systems, and that biomedical innovations increase the potential of how we can improve health, but we need those organizational changes as well in order to bring that potential into practice. That implementing innovation is a major challenge for every health system, and we've made progress in understanding it through academic research and implementation science, but we've mostly focused on how to learn within systems. We have this potential within Europe where we could learn from each other, but we need more work to understand how to do that. And the aim of 2REACH was to address this and to lay the foundations for us being able to ensure the future sustainability of our health systems in Europe, to reflect our shared values, and to be able to do so through learning between each other, and for 2REACH to provide the tools to enable us to do that. And at that point, I will hand back, George, to you, and I hope that that's provided a helpful introduction to the issue and to the challenges that 2REACH was trying to meet.
Nick, that was a beautiful introduction. Thank you so much for presenting that so clearly. I felt that your explanation of the rocket science and the helping us understand really these challenges in that way, those metaphors were beautiful and simple. And I was very challenged actually by you talking about scale up or variation being the biggest challenge, because I think if you had been at all of the sessions of the conference, that theme doesn't even come up. So hence the very importance of this session to say, maybe you need to look here. So thank you for doing that in a way that is so clear. I think people will have a lot of questions for you. And what I want to say is, people, please use the Q&A down the bottom. And at the end of the session, after we've heard from the rest of the speakers, we'll come back to that. So Nick, if you don't mind hanging around, and we'll come back to you after we've heard from our next two speakers.
Listening.
So you helped us understand. Thank you. So you've set up the situation really well, and you've explained that this is the situation that led to the 2REACH project being developed. So the EU funded 2REACH project, EHMA is a part of that, and it's coordinated and supported and funded by the Horizon 2020 Research and Innovation Programme to prepare a joint European research programme aimed at producing research, evidence, supporting healthcare services and systems to become more resilient, effective, equitable, accessible, sustainable, and comprehensive, all across Europe, but also abroad. So I think now that you've seen sort of the context Nick's described, you can understand what is this project really wanting to achieve. And to help you understand the ways that they've gone about doing that, I'm going to introduce you to Johan Hansen and to Professor Ellen Nolte. Now, Johan Hansen's been coordinating NIVEL activities in a number of international networks and collaborations. His main research interests are health services and health systems, with a particular focus on the organisation of health and care services, the transferability and upscaling of such services, and the relationships between health services, research and policy making, including priority setting. And then Professor Helen Nolte has expertise in health systems research, international healthcare comparisons, and performance assessment. And over the last decade, she's led a program of work around international healthcare comparisons, and she's developed an internationally recognized research portfolio around innovative service models that seek to better meet the needs of people with complex and long-term health problems, with a particular focus on care coordination and integration within and across sectors. And so what they're going to present to you now is tackling the key issues surrounding the innovation transfer and this policy brief that 2REACH has done. And they're going to speak to that now. So can I give the floor to them? I think Johan, you're going to present first.
Thanks, George. I don't know if this is a sort of a lottery, but let me at least follow the order that we had in the agenda, and then I'll hand over to Ellen. And thank you for the kind introduction. In a few seconds, I will also share the slides that I prepared. And thank you, audience, for joining this. I saw in the participant list we have quite a nice group of around 50 people. Coming from a lot of different backgrounds, at least based on the names that I recognized, and also geographically, with people from Finland, from Spain, from Italy, from my own country, the Netherlands, where I'm based. And I think that kind of conversation we're having here in the EHMA setting, even though we're all stuck to our own cities, our own homes, is really quite valuable to be able to share and learn and to reconnect, basically. Let me put up the slides indeed as well, and see if I can do it as fluently as Nick did. Because what I wanted to do is take a step back in a way in between the presentations that Nick gave and Ellen will give on sort of the theoretical framework that we have, is more on the priority areas where we should direct our attention to. What are the topic areas that are really those where we can learn most from each other and where we need to learn most from each other, and use that as an input for a future partnership on transforming health systems. And in the closing presentation by Sabrina, she will elaborate a little bit more about that. But in my feeling, and it's good to point that out, this is not a project presentation of a group of people showing this as our work and you should read our articles. This is really a movement about how EU member states, but also countries outside of the EU, Norway, Switzerland, but also outside Europe, Canada, the US, what have you, are willing to learn with and from each other, and are willing to collaborate and see how can we strengthen our ties. And in these times, I think that's really quite important and valuable. The general angle of To Reach is in a sense that we look at two main types of issues. One is really to look at the challenges ahead, what are the problems we're facing now, but also in the longer term, and what are the solutions you need to address those. So a problem-driven approach. And when we talk about new solutions or innovations, it might sound very sophisticated, but as Nick clarified quite well, this is not always about very refined technological solutions. This can sometimes also be simply manners of organizing care as usual in one country, which other countries have not yet been able to implement or had not thought about or need to are not yet prepared for yet, and need to organize the systems in a different way to do that. But in order to establish that change, you need to know whether that innovation or that good working practice, I want to avoid the term best practice, whether that can be implemented and transferred in other settings. So this is really about focusing on the domains that will dominate policy agendas in the coming years. And I think we have that conversation now on a daily basis within our countries as well. I wanted to also take a step back and put it in the context of what Chalmers and Glasgow have pointed out to as the waste of research funding, the fact that there's a lot of money being misspent on research, in part because of reasons of bad design, of bad execution, but also bad dissemination and reporting, which makes it a lot of this research being underused. But a core element is also that are not addressing the right questions. And with that waste and with that, and especially now with scarce resources, it's even more important that we think about what are the core elements that we should direct our attention to. So I want to direct our attention to that research that's not only, and that funding that's not only supporting research in a very general way, but also really directing our attention to implementation of policies, of services, and focus on how can we improve that return on investment. And for this, I really want to focus on the starting point, the types of questions to be addressed, and are we looking at the right questions, and are we asking the right questions, and are we asking them right in a way. And for this, our mapping, the exercise that we did as part of the project was really to look at those problems where we believe you need to focus attention on, within the health system, but explicitly also beyond the boundaries of the healthcare system. The interactions between health and social care for sure, but also how educational systems, welfare in general, employment policies, how they affect the health and well-being of our citizens, and how to learn better on how to improve them from a health angle. For this, we looked, of course, at documents, at reports, scientific articles, scanning reviews, strategic documents from member states, from at the European level. And I won't show or quote any of them now. I only wanted to flag one simple example, which is a nice one, I still think, the state of health in the EU, trying to map from a sort of a policy angle, what are the core problems. And for one highlighted example, prevention is a typical example that we often talk about, but we are simply not able to get that right yet. And as a sort of a teaser, this afternoon I saw that the Commission, OECD, but also the European Observatory on health systems and policies that Nick is working in as well, will be launching their new event, the new State of Health in the EU. And I'm not involved in that initiative. I'm simply a fan and admiring that work, and I think it's a good point of reference also for us as researchers and people in the field to look at, okay, where do we stand as a community and as a continent almost. As another element, as input, we conducted a number of stakeholder consultations, part of which were roundtable meetings, and this is an example in Malta where the Maltese team also got the involvement of the Ministry of Health, or actually the Minister of Health, which was really quite nice. Also showcasing the importance of liaising not only among researchers, but also really with stakeholders and policymakers, industry, etc., to have a broad approach. And the other element was an online consultation. And some of you may recall that one of those emails that you regularly get from EHMA was an email to ask if you would be able to provide input on the consultation that we had. And that really was a valuable source of information for us, trying to learn and see what are the priorities that you from the field within your own domains and your own countries were able to identify. And the response was really quite enormous and valuable, and on which we, but also the future partnership, can still build. Then, as a sort of a main summary of what we found, and I'm not going to go into detail a lot of all the specific questions and subtopics, but I'll highlight a few. But the overarching message and the overarching pattern that we saw is really an overarching priority from a disease-oriented and patient-centered care, from a demand-driven way of organizing care to a person-centered model of care. And this is really about self-management. It's about strengthening health literacies, but this is also about how to organize care in such a way that it really supports individuals and fits the mold of the patient and the citizen rather than the other way around. And for this, you need to do a number of things. And the one thing we often talk about is, of course, how to break down the silos, at least in those areas where it's most needed. How to ensure better coordination, better integration within the healthcare sector and across the healthcare sector and other fields. Next, as a sort of a supporting domain, you could say, there are really a number of sectors that stood out that need more attention, and where a lot of the grand challenges that we often talk about, aging, increase of chronic diseases, really have a central role in long-term care for obvious reasons, also with the demand of placing care closer at home, the new roles and the repositioning of hospitals, also in relation to other parts of the health sector, and the strong positioning, but also still the lack of how do you say it, the lack of success in really strengthening primary care, of which we've been talking about since Almaty and even before, but really making it quite difficult how to really integrate primary care, how to strengthen primary care, the team composition within it, and also with community care. And as an extra domain to highlight, mental health care as a really a domain that has been underappreciated and under lack of attention for quite long, and which needs to be strengthened, not only among the mental health services as a whole in itself, but also vulnerable groups within the population, for example, adolescents, immigrants, refugees, etc. And then a number of areas that are really quite instrumental across all these sectors: human resources, the workforce capacity, the tasks they have, digitalization. We often talk about that, but really to get that right in a people-centered way, so it can really support also patients, citizens, and not only the healthcare system, and reducing workload rather than sometimes increasing it, is quite a challenge. Quality, of course, and the wider governance model that also Nick referred to. And this is not really new. We know this in a way. This is quite consistent with other fields and mapping exercises that we and others have done as well. And this is one example of a previous one, and I could show more, where there's really a lot of synergy between these types of mappings, which is in a way is reassuring, because it shows that we got the picture right, but it's also really frustrating because it shows that a lot of the priorities that we've been talking about for years have not been able to been resolved yet. So there are barriers that need to be solved, and we need to look at things differently. And like I said, Ellen will talk about that in a different way in a later phase. One example I wanted to highlight is workforce, because within these sectors there are specific elements to address, and workforce, for example, refer to staff shortages, also better predicting workforce. One element that struck me at the time was something that came out of national consultations to better take care of our healthcare professionals, and to not only look at the health of the population, but also the health of the workforce itself, redistributing tasks and responsibilities, and also looking at organizational reform in the context of skill mix and professional development. If you want to introduce new measures, to really start also from the impact it will have on, like I just said, on workload, on whether it will make things easier and smoother, or make it actually more complicated. And as that example that I just mentioned, health of the care workers, zooming in a little bit more, it's really about issues like burnout, absenteeism, isolation, harassment and violence. And these are, in a way, you could say, these are not research questions yet, these are problems. But these are the types of problems in a problem-driven approach that need to be tackled, that need to be approached with a research angle and translate that to a research question that can be answered, preferably in a comparable way also between settings. And then the world changed, you could say. The world closed, and we found ourselves, all of us, in a different setting, in a different environment, where care as usual, business as usual, no longer applied. And that was, and still is, for a lot of us, quite a stressful period in time. And when you think about that, the implications it has on the organization of services, these are questions which are in a way still open. But it is easy to say this is a game changer. This is something which will really change the way we think about how to organize care, how to strengthen our systems. And I would say maybe it's not really a game changer per se. It's an amplifier. It's an amplifier of what we as healthcare community, what you as EHMA constituency have been saying for a long time, also to our politicians, that to increase wealth you have to start with health. And that you need to strengthen the system. And in that amplifying role that COVID crisis has had, of course, there are some differences in priorities between those that we see now and the ones that we identified earlier. For example, crisis preparedness, to be honest, that was one we didn't identify at that time as a crucial element. But we did, of course, see the importance of, for example, vaccination hesitancy as an element also in prevention, and the barriers that are faced there. And at that time we mentioned it, but of course now in the current crisis, that of course has moved up quite a bit in our priorities, in the attention it should get in, for example, Horizon Europe, national level, and where we should learn from each other. But apart from those shifts, you can also see that there's actually quite a lot of patterns that are still quite the same. And let me illustrate that also with the prioritization that you see in a few other documents and materials and conversations that are now taking place at national and European level. And one is the EU for Health program. And of course, this is not yet set in stone, it's still under negotiation, but we do see the contours already of what that new program will be like. And the same goes for Horizon Europe. And if you look at the program of EU for Health, then you'll see, of course, there's a lot of elements now on cross-border health threats, on availability of health products and crisis-relevant products, and the same goes for Horizon Europe. But you also see, again, the echoing of the importance of the resilience and sustainability of health systems, the use of digital tools, for example, and the role of the EU in a global health setting. If you then zoom in, for example, on cross-border health threats, you see again the same types of priorities and the same dimensions arise that I just described. The importance of prevention, of monitoring, surveillance, attention for vulnerable groups, mental health, and the health workforce, to name a few. Last example, and then I'll close and hand over to Ellen, is the expert panel of effective ways of investing in health. They just recently had a draft opinion on how to respond on the COVID crisis. And again, you see the same types of priorities emerge: workforce, collaboration, ICT, strengthening primary and mental care as a few examples. And these are quite valuable. This is also showing in the amplifying role of all these dimensions to keep our systems afloat, so to speak. And one element I quite like in all these patterns is the improvement and the willingness to share and improve our learning. In the EU for Health program, we already had best practices exchange, but I think that's now being supported even more, how to learn from each other. The expert panel as well, how to establish learning communities. And this as a bridge also to the future partnership is also something you see in Horizon Europe. So with these priorities and with these challenges, the main question we face now is really how to do that best and how to make sure we learn from each other in an efficient and a robust and a comparable manner. And for that, I'd like to hand over to Ellen.
Thanks very much, Johan. That was great. Again, I just want to remind the audience, you can put your Q&A into the chat box at the bottom of your screen, and we're running over time. So what I'm going to do is, we've still got time for all the speakers. So I'm going to hand over to Ellen Nolte in just a moment, and she'll still have her 10 to 15 minutes to present, because she's got some really important stuff that I think you need to hear about. And then Sabrina Montante will still come in at the end with her 10 minutes. It means the actual live Q&A at the end will be much shorter. So please make the most of your Q&A chat now. And I'd invite the panel, you can also write responses as those questions come up. So without further ado, over to you, Ellen. We don't hear you. Okay, that sounds more connected. Can you try again?
Can you hear me now?
Yes, clearly.
Okay, sorry, I dropped my laptop the other day, which wasn't very good. And it makes weird things. Well, thank you so much for having me today. And I just wanted to follow up on both Nick's and Johan's presentations and really talk about the other bit within to reach that we've been thinking about, which is what do we really know about transferring service and policy innovations between health systems. And a lot of what I'm going to say is sort of repeating what Nick and Johan have mentioned in different ways. So I'm going to whiz through my slides, but I just to assure you we can make these available for you afterwards if you're interested in more detail. So just to come back to what Nick was mentioning earlier about what we think about when we talk about innovation within the health system or health service, and it's often linked to the technological innovations such as drugs, such as diagnostic tools, such as therapies. And I think these are really important, but we also know that the drug or the diagnostic tool or the therapy in itself will not disseminate itself. So for implementation of such a technology, we need to ask a number of policy questions. For example, who will deliver the technology? Who will pay for it and how? How ensures that the right people will actually be able to access the technology and if so, in an equitable way? What is the most appropriate setting for delivering the technology? Who ensures that we actually have enough supplies of this technology and people to deliver that? And finally, which is also key really, who monitors that the new technology achieves the intended effects? So there are a whole host of questions already highlighting, though, in order to introduce this new technology, we actually need to think about the service and system context within which the innovation is being introduced. So inevitably, the innovation will be affected by the service and the system and the way we organize our health services and systems, but also the systems in itself will impact on whether or not, or the degree to which this innovation is going to be effective. So there's this very close link between technological innovation and system and service innovation, as Nick has already alluded to. But service innovation in itself will become increasingly important as well, given the various challenges which Johan has highlighted. There are numerous, which really require us as policymakers, as practitioners, as researchers to really rethink more fundamentally how we organize, finance and deliver health services. And what is important to understand, and Nick, again, I refer back to what you were saying earlier, we do have evidence for a number of very important innovations in the service delivery sphere, just thinking about stroke units, or even the wider public health universe, as it were. For example, so reduction strategies. And even though we do know that the evidence is actually pretty solid on both of these innovations, the level to which these are being implemented and transferred across countries is still quite varied. And this is just some illustration from a recent study which looked at the number of stroke units per incident of ischemic stroke cases in Europe, showing us that it's actually wide variation of implementation of an innovation which has proven evidence of effectiveness. So what we really need to know is what are the factors acting at the service and the system level that enable or even hinder the successful implementation of evidence-based interventions such as stroke care, or innovations, I should say. As both Nick and Johan were saying, there's of course huge potential for learning, and this has been happening over the last 150 years. So countries have been learning from each other for quite some time. But this has often happened in a rather haphazard way. And I think what To Reach is really emphasizing is that in order to really optimize cross-country learning, what we really need to understand better, or reinforce potentially, is the systematic comparative cross-country health services and systems research in order to help us disseminate potentially promising innovations much more rapidly, but also ensure that innovations that may not be suitable for a given context will either be adapted or perhaps even not transferred at all, to really optimize, in the systems which are constrained for various reasons, the resources that we have available. So just very briefly, what we did in our work package was really to go back to the more conceptual literature and really try to understand what is it we already know about successful transfer between countries, but also what it is we need to know. And as part of that work, we developed this framework. I'm not going to go into much great detail about this framework. We can share that afterwards. I just wanted to highlight a couple of issues that are really important and where we do know these are really quite crucial for effective transfer. This is points around the actual service or policy innovation, the process of transferring, and you might also say translation of evidence elsewhere, and context. Context is something which I'm going to come back again and again and again because it's just so important. Just very briefly, if we think about sort of transferring a particular service or policy innovation, one key issue that we need to think about is, the actual attributes of the innovation in itself. And this has been fairly well researched in the whole innovation literature, and I'm not going to go over that again. But I think what we need to be aware of, that even if an innovation does meet all these sort of attributes, being, benefiting society, is adaptable, has evidence attached to it, this in itself doesn't guarantee that this innovation is being transferred, because it interacts so closely with the people implementing it, adopting it, disseminating it, but also the context within which it originates and is being implemented. Nick has mentioned the issue of complexity, and this is a really important aspect because complexity, of course, can mean different things to different people and in different contexts. And even more technical solutions may be difficult to transfer where the receiving context actually isn't suited towards receiving it, or where the system isn't ready. And we need to understand that, these conditions of readiness, as it were. The other aspect which I've alluded to already is we do know that innovations that have a very strong evidence base are more likely to be adopted, implemented, disseminated, and transferred elsewhere. But it's still quite uncertain what we actually mean by the nature of evidence. So of course, there's the classic randomized control trial evidence, which is important, but it doesn't necessarily tell us how easy it is to implement this intervention or innovation in real life, in day-to-day life. So we need this tacit knowledge, which I'm going to come back to in a moment as well. But also, as was mentioned earlier, evidence of effectiveness in itself is not sufficient to ensure that a particular innovation is being implemented in a given setting or even transferred to another setting. And I've given you the example of the stroke units. In order to illustrate a little bit more how we can explain how policies and service innovations move, we've used the example of diagnosis-related groups, which have been described as the single most influential post-war innovation in medical financing. And this slide, I'm not going to talk a lot about it. It just shows at the top the various countries, and at the left-hand side, the timeline from 1977 down to 2010. How this particular innovation, which was developed in the US in the 1970s by researchers at Yale University, and then really adopted and adapted to in a number of countries over the years. And what is interesting about DRGs as an innovation is that it does meet a number of key characteristics of innovations. Firstly, it's flexible and easy to modify. And it's both a set of principles as well as a technology. So in that way, it actually does meet the needs of a wide variety of stakeholders, which makes it much more easy to make it palpable and implementable. And thirdly, it's also adaptable to local context, which is a very key key attribute of innovations that are more likely to transfer. And this again allows adopters to really change it over time to make it suitable to the local context. I've mentioned context several times, and I'm not going to go into great detail about this again because it is just so crucial. What we do need to understand really is what are the particular characteristics of a health system that are really conducive to an effective and successful transfer of a given service or policy innovation. And I think a part of that, when we look for solutions elsewhere, for inspiration elsewhere, we tend to look at countries because they are close, because they share the same language, because they share the same history, but they may be not necessarily the best countries to look at. And I think there is a reason why a lot of countries look at to the US and perhaps the UK because of the shared language of English, which is much more universally available. And we kind of tend to overlook the service innovations in other countries, which perhaps are not using English as a way to disseminate the evidence and the knowledge around that. There's also an issue about the urgency. So something might be urgent in one setting, but not particularly urgent in another setting, and which may then determine whether we actually go actively out to look for solutions or rather take a more passive approach. But I think, again, here we need to really understand, is this particular solution actually suitable to meet our policy problem? And this is something which is really, really where much more research needs to be done around what is it we need to understand about this innovation in order to ensure successful transfer. And I think DRGs, again, are a good illustration because, and I'm just very rapidly go through it, it serves different purposes in very different contexts, and which has perhaps aided its wide dissemination, certainly across European countries, and why certain countries went for it, if I may say so, and others perhaps more slowly because of various other issues, because of fragmentation, or perhaps the pressure, the policy pressure wasn't as strong in some countries than in other countries. The process of translation and transfer, I'm not going to spend too much time on this. What I want to highlight is, and Nick and Johan, you've both mentioned that, is really something around the key role of these social actors. And this is something which we haven't really quite our head round in terms of how we can capitalize on that, but also how we understand their role in potentially also disseminating less successful examples that are potentially not beneficial for receiving countries. And we do have, we talk about individuals, policy ambassadors, organizations, just thinking about the DRG, again, very much promoted by the group in Yale, who also acted as consultants in disseminating this work. And knowledge and science networks and policy networks, and increasingly national and international meetings and conferences as a platform to learn from other countries, which are important. But again, we need to understand what is it? How is it that certain innovations are being promoted and not others? Is it because the others are not well established, or because there's a lot of tacit knowledge that we don't know? So I think there's a whole host of issues that we need to understand better. And just sort of come back to the DRGs, I have mentioned the role of Yale University in the dissemination, the wider spread, but also it was taken up quite rapidly by means of meetings of country and policymakers in a number of countries in the 1980s, which eventually led to a sign, or what someone referred to as research industry around DRGs, which developed into the Patient Classification Systems International network, which really provided a knowledge network to further develop this technology, this innovation, and aided its dissemination. So I just want to close with, and I've already actually taken away a lot of what we need to know, because we still need to know quite a lot about how we transfer effectively. And I've mentioned the role of international institutions and organizations, and what their particular features are around facilitating transfer, but also potentially saying, actually, this particular service innovation or policy may not be suitable for transfer for a number of reasons. I've mentioned the specific features of health systems, but also I think what is important to understand, a number of countries have implemented national level support structures, such as France, Germany, England, really kind of providing support to evaluate service and policy innovation, and really taking this evidence a step further to help us understand what works in what context and for what populations. Again, I'm coming back to the type of evidence that is needed. It's both the research evidence, it's the tacit evidence, it's the local evidence that is required. And I think an important aspect, I think this is a really key one, is to really understand what is it about that innovation that makes it work in one setting but not in another one. And I think we really need to better understand what is acceptable and valued in one system may not necessarily transferable to another one. And I just give one final example. It's the translation of a Dutch district nursing model, which is being developed and implemented across the UK. And we see that actually there are challenges with that, even though the model in itself is very helpful, but there are implementation challenges because of the differences of the institutional context. And finally, we need to understand the impact of service and policy innovation on health system performance. And this is an area we don't really understand well at all. I would like to thank Peter Groenewegen, with whom I've developed this policy brief, and of course our work package 3 partners who are listed here. Thank you.
Thank you very much for that, Ellen. That was also very interesting, and I wanted to give it time, because clearly this is a subject matter exactly that people are tuning in for. I'll remind people you've got an opportunity to ask questions and answers in the text box, and I can see that that some questions are coming through now, and we'll try and get to them at the end, but so we can also make sure that we hear really well from Sabrina Montagna. I'm going to hand over to her in just a moment. She's the Senior Advisor for EU Affairs at the Italian National Health Service. She's Brussels-based and working in the EU public health policy field with EU policies, strategies and funding on health research and innovation. And she's worked internationally and across EU organizations for many years. She brings a lot of expertise and she's coordinated this project. So Sabrina, I invite you forward now to tell us about what is the future of this.
Not an easy question, right? Yeah. I will try to be quick because I think much has been said by previous speakers, and I think that what people and all of you wants to know is how can we then move from to reach to the knowledge built by to reach to a coordinated action at European level that in the end translate all these important points into actions. So to reach, just a little introduction. To reach indeed is a project made by 28 partners from 21 countries, and the beauty of this project is that was able to bring together actors from ministry levels, from funders, funding bodies, funding research, innovation, on health research innovation across Europe and not only Europe, international organizations, public health institutes, and research universities as well. So different group of partners and actors. Those social actors that Ellen has been mentioning, in a way, have been brought together in the project to reach. Now, this is quite new, I would say, at European level, because, I mean, indeed, to reach is a coordinated support and action, is not a research innovation project, which aimed to build, to prepare a joint European research innovation program aimed at producing evidence supporting health and care system to become resilient, effective, accessible, sustainable, comprehensive. So we did have in the past the project funded by the European Commission on some segment of health and care system research innovation, but we never had really an action try to bring together all these actors to really move forward to create a joint European research innovation program, bringing together all these different actors to achieve this ambitious and important goal. So objectives of to reach indeed were to produce the strategic research agenda, and you heard the previous presentation were really the core of the strategic research agenda that was published back in 2019. After this, you know, methodology built by colleagues, indeed through desk research, consultation, roundtable discussion at national level, and then meetings of a task force made of these different actors to really make sure that all these elements were brought together in the strategic research agenda. Other big objective of the project was indeed to broaden the coalition of member states and associated countries funding bodies, and I think we reached that purpose because we are a community of different, and today actually I'm speaking on one of those countries, indeed Italy, that has been has the honor to coordinate this project that is now among the countries involved in building this future program at European level. Others are participating as well. Some of them are partners of To Reach, some others are not partners of To Reach, but will become partner of this future program. And then, of course, To Reach wants to inform and help to contribute to this future joint research program. You can see down there a calendar, like a sort of timeline, more than calendar, with the steps, the milestone taken, and that has to be taken towards this important goal of building this future program for research innovation in this field. We started in 2016 with the funding of To Reach. That was, in the end, the result also of a strong lobby, allow me to use this word, lobby, at European level, really to make sure that this field of research was actually gaining the space and needed trying to really have an action aligning the priorities, building a future program to work together between member states, associated countries, and the Commission. In the end, TO-REACH was funded. We published, as I said, a strategic research agenda. And then after the publication of the strategic research agenda, the European Commission included that this joint program, this candidate research program in the strategic planning and of Horizon Europe, that will be the future framework program for research innovation at European level, starting from next year. And indeed, a group of member states and associated countries started working on a proposal for a candidate partnership, learning from previous initiatives, and among them TO-REACH. Now the proposal for this candidate partnership was published in June this year. And then after that, countries were asked to provide commitment to this action by October this year. And the countries committed. And now the countries will have to build a strategic research innovation agenda of this future partnership that will, in the end, make sure that this partnership won't be anymore a candidate, but will be, in the end, a partnership included in the Horizon Europe Work Program 2021-2022 and be launched indeed in 2022. Here is a slide that I took from the European Commission, because in the end it's summarizing a little bit what we mean for European partnership, because in the project of TO-REACH we talk about joint research program. We are not really specific in mentioning partnership, because when the project was funded, there was not yet the structure of Horizon Europe in place. Now we know the Commission proposed the European partnership as a new way to run this program, making sure that there is a simple architecture, that we have a common set of criteria. We try to avoid duplication, and in one program we try to combine the experience of previous initiatives indeed. There are three types of partnership. That one that will be dedicated to the future of this field of research innovation will be a co-funded, in which member states, associated countries, and the European Commission will allocate resources in cash and in kind to run a program in this field. A program that will launch goals, will launch new research innovation actions, but at the same time will conduct some research innovation activity, implementation, training, capacity building inside this big program. Here you see the partnership portfolio that it will be in future Horizon Europe, indeed one dedicated to health and care system transformation within the cluster health. And here you see the general objective of this future candidate partnership, that will be to ensure the transition towards more sustainable, resilient, innovative, and high-quality people-centered health and care systems. Why then a program? Why in a partnership? After all that we've been listening today, because we realize that there is a gap in research innovation in this field. We think there is a gap, and we can do more to ensure that knowledge translation is happening, that we reach policymakers, we inform policymaking indeed, and that there is a gap in implementation and scaling up across Europe on transferability of this innovation across countries, regions, settings. And we think we should strengthen the research innovation capacity indeed. Of course, member states, associated countries are involved so far, but the regional dimension is crucial, and regions will be involved. And this co-funded partnership should have a vision of 7 years. So the objectives that will be set should be long-term, I mean 7 years time. The impact. So what we will, with this partnership, this joint initiative will do, indeed, fill the gap in EU collaborative and coordinated research innovation activities, with a focus on implementation of innovation, implementation of innovative solution and practice. But when we say innovative solution, we have to, in the proposal online of the partnership, you can see that countries have realized that these innovative solutions don't really necessarily refer only to service, only to technological innovation, but also service and policy innovation in health and care systems. We need new evidence-based strategies and policies. We need increased capacities indeed, and we need to build stronger local regional health and care communities to facilitate the uptake of successful innovation. And last but not least, in the philosophy of Horizon Europe, indeed, we need citizens to be involved, and we need health and care actors increase their digital and health literacy. Last slide. What I want to say is that there is this work, this program won't be necessarily only the result of only to reach projects. So the challenge here is to integrate the work of different initiatives that have been funded in the past. All initiatives that have really linked and many synergies with the work of To Reach. I think about the Active and Assisted Living program, which is a program funded since 2008, and have funded over 220 projects so far, in particular in the field of old aging and management of chronic condition, and the use of tools that are ready to the market to support the mobility of older people and to support informal carers. We have the joint programming initiatives that has been focusing on demographic change so far, and announced the collaboration between European and national research programs related to demographic change, and has published itself as well as strategic research agenda in this field. And then we have the big initiative of the European Innovation Partnership on Active and Healthy Aging that has collected actions and practices across regions and local actors across Europe in the past 10 years. But it's time now to look at these practices and really understand what is working, what is not working, really building a conceptual framework that is able to really assess what we can implement and how we can transfer innovation in some practices across Europe. And then last but not least, Joint Action PRODIS as well, which is a public health joint action, which is looking at practices in the field of chronic disease and prevention and promotion across Europe, and has it still indeed a repository of practice as well to look at. We need to align with parallel initiatives, Mission on Cancer, innovative health initiatives, and other initiatives across Europe. Of course, we need to learn from the past, but we shouldn't be shy and not innovative enough to think about a new program, a new partnership that is bringing really a fundamentally novel approach to the problem. So yes, learning from the past, but creating a new program in which all these actors can work together to identify and test innovative solutions and realistically tackle the challenge that health and care systems are facing. And I would end by saying that this is something that has started since a long time, but it's actually, you can see now that what we are living with the pandemic is making the momentum at European level extremely important, and that I think it's time now to move forward. Thank you very much.
Thank you, Sabrina. And that certainly is a sentiment that's been felt across the conference. And I can see we've now got quite a few questions that are coming up, and I thank the panel who've been answering them in the background. This session is scheduled to finish in 2 minutes. I'm going to extend it for a couple more minutes so that we can deal with some of these questions. So I'm going to go firstly to Ellen. You've clicked on one that you want to answer live.
Yeah, that's the question. I think it's kind of linked to many other questions. So Ben BR was asking, what are the elements that are easier to be lost in translation that you recognize in your work? And I think one of the elements is what I think it's widely referred to as tacit knowledge. So when we look at innovations, we always, of service innovations, say advanced practice nurses, say a given integrated care model, we always see documented the key things, like how it's financed, the key people involved. We never really see the other bits of work that need to be done for this particular innovation to work locally. For example, the additional opportunist, the kind of what you call it, the time that is being invested in actually training people, the time that is being invested in making sure that the management system works, the time. So all these sort of smallish organizational features that are really key to make something work. These are often not documented, but these are going to be key for us to understand whether or not these types of mechanisms are actually available in a different setting for it to work. And this is really a call for really trying, it also relates to the question about context. Context is really trying to understand what is specific about the local context that is not transferable, and then what is more general, which is actually transferable. And I think we need to do more work around that, as classifying that a bit more strategically.
Ellen, that's interesting because there's also been a lot of chat on the conference platform while this session's happening. So people who are in this session are chatting also privately saying, this is great, it feels very abstract. And I can see a question from Annelies Wardenberg, and she says, dear all, we're talking about innovation of care systems. Can the panel members enlighten us on practical lessons learned in view of the different care organizational systems? And she goes on to make some other comments that you can read. And I think that reflects for us, a lot of the people in this conference are health managers. They're interested in implementation as well as strategic agendas. So Nick, do you want to speak to that point?
So there's quite a famous research paper which is titled, "There's nothing as practical as a good theory." That sounds like the kind of thing that an academic is paid to say, but I actually think that it's helpful because it can be part of the reason why we developed the NAS framework, which I mentioned, and there have been many other frameworks which Ellen has also resolved, was exactly to try and give people a set of tools. So if you if they were to search, for example, for our website, there is we also have a tool called the Complexity Assessment Tool, which essentially tries to take those sort of groups of stakeholders and processes and exactly the kinds of things that Ellen was just talking about that we tend to lose sight of, and turn those into a sort of a means of trying to map and think about the people and the processes and the change process that people need to think about. So I'll go and find the link and put it in the Q&A so that people can find it quickly. But it's thinking about that checklist of who are the wider people who are going to be affected by this, who has to change, what do they get out of it? And just to give one tiny example, electronic health records. People have talked a lot about the benefits of electronic health records, but quite often the work is done by nurses and patient-facing clinicians, and the benefits accumulate to administrators and managers and people overseeing the system. So the value proposition is completely, where the value is realized and the people who actually have to do the work are not the same people. And you need to address that in thinking about how do you actually make this useful for the people who you want to also be changing and doing the work. Does that make sense, George? Yeah,
absolutely does. So let's try and finish off some of the other questions. I can see Annelies also asked for you and less in terms of the ingredients you mentioned. And you're on mute, so if you just want to unmute.
Yeah, you broke up halfway through, sorry.
So Annelies also asked a question about, she wants a few examples of what went well and less in the terms of the ingredients that you mentioned.
Yeah, so I mean, I know ingredients is a bit of an abstract term, but I think what we've seen is, for examples of cross-national transfer of a given innovation. I'm just going to give the example of the transfer of an advanced practice nurse from the US to the English context. I think the key challenge was that the innovation was introduced because it was seen to be the right thing to do without actually doing a needs assessment first to understand, is it actually the right innovation for this particular organization or system to solve the problem it wanted to solve. So what they introduced this advanced practice nurse without recognizing that there was already a number of district nurses locally who felt threatened by the introduction of this new role. And overall, the issue was that it didn't quite meet the needs that they hoped to meet the need. It met another need. But the overall emphasis was on reducing hospital use, and this intervention or innovation did not actually lead to that because it wasn't really quite suited to meet that need. So what I'm But I think the key ingredient is for any innovation implementation is to really understand first, is this particular innovation actually going to address the need I want to solve, the problem I want to solve? And this is going to be even more crucial in the international context. So I can't give you a clear, answer on that, but I think it comes back to what Nick was saying. We need to understand what is it that this innovation does, and do we have the different things in place for it to work? And if we don't, do we need to adapt? Can we adapt? If we can't, maybe we just need to find another solution.
Okay, we've got one more question from Maria Jose, and then we'll have to finish up in about a minute after that. And this is for Sabrina. Sabrina, you have highlighted the importance of the regional dimension. How do you think you could be the best way to involve them in your partnership to merge their priority with the national priority, taking into account the regional health system differences? Maybe that might be a good one for all the panel to sort of finish a final comment in regards to that. Starting with you, Sabrina.
Thank you very much for the question. I was working for regions before moving to the national level, so it's actually a question that I feel very, very close. It's a very good question indeed. So regions will need to be involved. Of course, this is the future program will be a program managed by that will follow the formal procedure put in place by the European Commission together with member states, associated countries. So for the moment, countries are those that are in direct contact with the European Commission to build the future program. But actually, countries are already brainstorming on how to make sure that the regions are involved, perhaps through national mirror groups in which regions and different local actors or other stakeholders at national level can be involved. Let's say the national delegate behind and then in the future being actually involved as partner of the program. So it's a work in progress. Now at the moment nothing is fixed, just for you to know that countries are brainstorming about it, and through following the formal procedures, definitely regions will be there.
Thank you. And from you, Nick.
One very final thing, just to say, you mentioned the policy briefs right at the early on in your introduction. We do hope to have the policy briefs from 2REACH published with support of the European Observatory in the coming weeks, possibly months. But they're there. The drafts exist, and we hope to have them published really soon. And so I'd invite everybody to have a look out for that.
Great, and Sabrina answered some comments about that as well. So if people do have more questions about that, check out what's been answered in the Q&A. Johan.
Well, if I address the regional component, one of the things I would link it to in terms of the priorities we identified is really also, and in terms of, as one example, access to care and the inequalities you see between regions within a country, between rural, remote regions and more urban regions. And that in itself is not only a national priority, but it is also showcasing again the added value of comparing yourselves with and involving and willing to learn between, for example, rural regions between countries when it comes, for example, to workforce shortages. And I think that type of networking, that type of involvement also in a future partnership or via EHMA and other channels, I think would be really valuable, not only to learn between countries, but also really between similar regions, similar types of hospitals, etc.
Thank you very much. Thank you to the speakers. One of the key things that we did talk about in this session was governance. And the next session coming up after this is by the Good Governance Institute looking at governance. So if people want to talk more about governance as one of these elements, do go to your conference platform and check out that session. And there'll be several abstract sessions also running in parallel. And don't forget to join the closing plenary that happens after that. There'll be obviously a lot more questions, and I can see just from the chats privately that have been happening, from the Q&A, lots of questions. Do watch this space. EHMA is a partner in this project, so we'll certainly keep communicating to you about it and linking you to these experts that we've had the privilege of hearing from. Sabrina Montante, Nick Fahey, Johan Hansen, Ellen Nolte, thank you so much for your time and your expertise today.
Thank you very much, and thanks for your support to the project.
Thanks, everyone. See you soon.